Nasogastric tube. A nasogastric (NG) tube is a thin, soft tube made of plastic or rubber that is passed through the nose, down through the throat, and into the stomach. It is used to deliver food or medicine to the stomach for people who have difficulty eating or swallowing. It can also be used to remove liquids or air from the stomach. Usually inserted to decompress the stomach, a nasogastric tube can prevent vomiting after major surgery. An NG tube is typically in place for 48 to 72 hours after surgery, by which time peristalsis usually resumes. Most NG tubes have a radiopaque marker or strip at the distal end so that the tube's position can be verified by X-ray. Indications: to decompress the stomach and gastrointestinal (GI) tract. To obtain a sample of gastric contents to assess bleeding, volume, or acid content. To remove ingested toxins. To give antidotes such as activated charcoal. To give oral radiopaque contrast agents. To provide feeding of nutrients into stomach or feeding. Contraindications. Absolute contraindications. Severe maxillofacial trauma. Nasopharyngeal or esophageal obstruction. Relative contraindications. Uncorrected coagulation abnormalities. Equipment. For insertion. Tube, usually 12, 14, 16, or 18 French for a normal adult. Lidocaine 2%. Hypoallergenic tape. Gloves. Water-soluble lubricant. pH test strip or carbon dioxide detector. Irrigation set. Continued. Ordered suction. Mask and goggles. Basin of warm water. Stethoscope. Syringe. Securement device or tape. Inserting an NG tube. Provide privacy and assist the patient into the high Fowler position unless contraindicated. Stand at the patient's right side if you're right-handed or at her left side if you're left-hand to ease insertion. Drape the towel or fluid-impermeable pad over the patient's chest to protect her gown and bed linens from spills. Help the patient face forward with her neck in a neutral position. Put on gloves to comply with standard precautions and other personal protective equipment, as needed, if splashing of body fluids is likely. Determine the length of the tube to be inserted to reach the stomach. To do so, hold the end of the tube at the tip of the patient's nose and extend the tube to the patient's earlobe and then down to the xiphoid process. Mark this distance on the tubing with the tape. It may be necessary to add 2 inches, 5 centimeters, to this measurement in tall patients to ensure entry into the stomach. Administer viscous lidocaine 2% for oral use, or nebulized lidocaine, as ordered, following safe medication administration practices. Ask the patient to sniff and swallow to anesthetize the nasal and oropharyngeal mucosa. To minimize injury to the nasal passages, lubricate the first 3-inch, 7.5 centimeters, of the tube with a water-soluble gel to minimize injury to the nasal passages. Instruct the patient to hold her head straight and upright. Grasp the tube, curve it if necessary, and carefully insert it into the more patent nostril. Aim the tube downward and toward the ear closer to the chosen nostril. Advance it slowly to avoid pressure on the turbinate and resultant pain and bleeding. When the tube reaches the nasopharynx, you'll feel resistance. Instruct the patient to lower her head slightly to close the trachea and open the esophagus. Then rotate the tube 180 degrees toward the opposite nostril to redirect it so that the tube won't enter the patient's mouth. Unless contraindicated, offer the patient a cup or glass of water with a straw. Direct her to sip and swallow as you slowly advance the tube to help the tube pass to the esophagus. Use a tongue blade and pen light to examine the patient's mouth and throat for signs of a coiled section of tubing, especially in an unconscious patient. Coiling may indicate an obstruction. Carefully advance the tube as the patient swallows and watch for signs of respiratory distress, which may mean the tube is in the bronchus and must be removed immediately. Stop advancing the tube when the tape mark reaches the patient's nostril. Use various bedside methods to determine tube location. Using capnography, if available, to detect carbon dioxide, which indicates inadvertent tracheal insertion. Measuring the pH of aspirate from the tube if pH strips are available and your facility allows pH measurement. Fasting gastric pH is typically 5 or less. Anticipate an X-ray to verify placement. A properly obtained and interpreted X-ray is recommended to confirm placement. Secure the NG tube to the patient's nose using a commercial securement device or tape. Discard used supplies in the appropriate receptacle. Remove and discard your gloves and any other personal protective equipment worn. Perform hand hygiene. Document the procedure. Special considerations. Provide frequent nasal and oral care while the NG tube is in place. If the patient has a deviated septum or other nasal condition that prevents nasal insertion, pass the tube orally after removing dentures. While advancing the tube, observe for signs that it has entered the trachea, such as choking or breathing difficulties in a conscious patient and cyanosis in an unconscious patient. For the next 48 hours after removal, monitor the patient for signs of GI dysfunction.